Thank you so much, Dr. Liu, for the wonderful introduction. I'm really honored to be here again in this venue. I think it's probably the third talk I've given in this series of event, and every time I found very inspired by my peer speakers, especially and also the audience. So today I'm gonna spend some time to talk about a project that we have been passionately working on since 2018, and it's been progressing very fast over the past few years, especially with the kind of event of a large language model. So I'm going to share with you some of those experiences we have got, and also lesson learned in this process of how to like move forward with this project and align with the advancement in large model in the space, especially in the healthcare setting where we have to be very careful about not providing information to patients that are not responsible and they're not potentially are secure and safe for them to use and consume. So this project is funded by both the National Agency of Healthcare Research Quality and also recently by National Institute on Aging. So today the talk is on this project called LabGene. So as you already hear the whole day, I probably shouldn't spend my time talking about what is agentic AI, but essentially, we're trying to change the paradigm from like one time like prompt, one answer to whole sort of process of generating a reasonably meaningful and useful high quality action based on the goal and making a plan and to be able to find tools and be able to sort of orchestrate a system that can solve problems. So this is just like a paradigm shift for many different fields, including healthcare. So in order to really think about how to responsibly do it, I think it takes a lot of efforts to figure out, especially in the healthcare setting where we have to be very careful about the decision-making process and also the human-in-the-loop process, because oftentimes the decision cannot be simply made by autonomous machines. And even though we have heard the news, for example, Utah State has approved the use of AI for prescription, without human supervision. But those are sort of limited in this controlled environment where they only can prescribe medicine to patients with already existing prescription made by doctors, and also they are just doing the continuous prescription if they have a medication or medical condition that are already well managed. So Gen AI is also very well suited for medicine in general. Let's not talk about the ethic part of it. In general, healthcare is very fragmented, and also the data is very fragmented. We have data from lab tests, we have data from pre-tech clinical notes, we have data from medical images and the voices. As you can imagine, in order to orchestrate a system that can take all of this kind of different data from sources and be able to orchestrate a solution for patients, you have to be able to have a very specialized system and be able to have very specialized agent to inject this type of data to provide meaningful interpretation and be able to orchestrate responses based on the responses and decisions made by all these different sub-agents to generate a reasonably good decision for patients. And also the decision-making process of medicine is oftentimes also longitudinal. It's like oftentimes not like a one-time shot because based on only what you observe right now may not be enough for medical decision-making to be adequately strong enough. You have to look at patient's history, maybe family history, maybe things that have happened in the past few years, and to make some decisions. So that is really kind of where I think Gen AI is going to be make a really big change. And at the same time, because of the safety concerns and also trust issues here, there's a lot of things we have to consider in order to really make this a truly responsible system. And there's a lot of recent papers I want to mention that talk about what is the difference, for example, between traditional medical AI to medical AI agent. In my lab, we actually have been working in this area for more than 10 years. When I joined FSU in 2015, we started to think about how to develop machine learning models to predict mortality for patients with heart diseases. And then we started to consider using medical records, not only structured medical data, but also unstructured clinical notes to use sort of deep learning method to embed those clinical notes into embedding space and concatenate them with structured data for make predictions. So we try to also develop the first few models and the methods integrating in the explainable AI methods into this space. We kind of published some of the first papers in this space, summarizing the landscape of explainable AI. So even with that, still the field has not been moved to really easily translate some of this medical AI innovations in the experiment setting to clinical setting adequately fast enough. There's a lot of problem with adoption, with the front, and also be able to not only make decisions based on the model performance, but also based on like what kind of interpretation can you provide to the end users to ensure that they adequately understand what actually why set up decisions suggested by AI for not only for individual patients but globally for patients of a similar category characteristic. So the medical AI agent, supposedly should be more autonomous or semi-autonomous, should be able to manage complex multi-step tasks and workflows, should be able to be more data-driven and goal-oriented and adaptive reasoning. Those are, I think, the ideal situations where like medical AI should be developed in this space of agent AI. But in reality, because of the requirement of regulation, the requirement for human loop to have human supervision, oftentimes this has to be done in a more careful way. So we have also seen studies published in the past few years, especially in the past 2 years, about like how to develop a multi-agent system to take into those different data modalities into this model to generate fairly rich information about patient cases. So, for example, in the study published in Nature Cancer, they demonstrated that if you throw this different data to generate ChatGPT models to generate like interpretation for patient cases, the case generated interpretation is very like not very rich compared to orchestrated agent systems where you take different data into different sub-agents and to be able to orchestrate a responsible answer that take into different data modalities from patients. And in my lab, we have also been collaborating with top-notch researchers from NIH, National Lab of Medicine, to develop this concept called Agent MD. This paper was published last year in Nature Communications. The idea is to take the published literature in PubMed and those papers that are talking about the risk score. We will take all of this kind of risk score-based publications and then translate this published literature into a computable score system that the AI will be able to take the medical notes of patients and directly identify which risk scores will be applicable to this individual patients and then generate those risk scores automatically. So I've done a lot of work to translate this kind of medical literature into risk scores and then validate how this would be better than using GPT alone in computing the risk scores. And there's a lot of really interesting results there. I really encourage to take a look at this paper. And also this study called Agent Clinic, published recently also by a group of researchers in China, they also propose this type of multi-agent systems that are in this paradigm of planning, action, memory, and reflection. In a sense, the planning is mainly focused on taking all this data and figure out like what type of kind of data processing steps should be applied in order to make sure that data is clean enough for analysis. And in action, there's like diagnostic tools, therapeutic tools, monitoring tools, predictive tools, and surgical tools that can take this data into from different sources and to generate responses and generate action. And then the reflection agent is focused on evaluating the responses to make sure that they are adequately high quality and accurate. And then the memory part is to take the real-time data and to also take the historical data to make sure that you can memorize information from these patients in a way that is meaningful. So the memory like includes, as I mentioned, like short-term updates for real-time data or long-term storage of patient history for learning. And so this system is conceptualized in a way that supposedly should make sense to individual patients and for clinical decision making. And what really is happening in the real world is a lot of companies, especially either small startups or big companies, they're trying to push those health tools to the patients and to the clinical setting quickly. So far, this clinical report was published in January 2026 by a group of researchers in Stanford that kind of look at the state of the current clinical AI space in 2026. And they found that there's a paper published in JAMA earlier this year too, saying like about 1,200 FDA cleared tools and 350 consumer tools now have generated a $70 billion billion-dollar market. And however, among those tools that are already considered FDA cleared AI medical devices, very few of them actually went through rigorous clinical trial research. That's because FDA right now does not have the adequate sort of regulations to regulate the evaluation and the approval of AI algorithms. They still treat these AI algorithms as medical devices. And if the companies go through this approval process through 510K clearance, they just have to demonstrate that those algorithms, AI algorithms, machine algorithms, have sort of equivalent predictive efficacy as existing devices, and they don't have to go through rigorous evaluation of patient outcome evaluation. So many of them are approved this way, but at the end, because of that, they have suboptimal evidence to demonstrate that they are actually going to be making changes in patient health outcome. And you look at really this FDA device summaries, very few of them actually publish their study design. Many of them don't talk about the sample size in the evaluation, and the majority of them actually didn't report even demographic data. So as you know, like a lot of medical devices, if your AI devices or AI algorithms are trained on the biased data or patient population that are biased for certain population subgroups, the algorithm is unlikely to be broadly applicable to the general population. So there's still a lot of gap there to make sure that you are developing these AI algorithms or AI devices or methods that are really going to be beneficial to the general public. So in my area, in my space, lab, we're doing recently a lot of patient-facing applications. There's still a lot of opportunity there in terms of producing AI patient-facing applications that can engage patients and can address patients' issues. But if you allow patients to directly interact with this tool without much supervision by real clinicians or medical professionals, there's still going to be a lot of issues there. For example, recently, you probably know, like recently ChatGPT released GPT Health as a tool within ChatGPT, allowing patients to directly interact with the ChatGPT and ask medical questions. And mainly the main benefits and change using that ChatGPT, like health variation of ChatGPT, is that your data that is sent to that variation will not be used to train the foundation model. So it's supposed to be more secure and safe. But the problem is, the model itself is not specifically trained for medicine to answer medical questions, and patients are responsible for orchestrate or generate the kind of questions that can be used for AI to give meaningful and accurate responses, which patient may not have that kind of literacy to really know how to deal with that situation. So still, based on the recent research findings, they found that if you can give the same patient profile to medical professionals and to patients, oftentimes patients may not be able to reach accurate final diagnosis and final disposition compared to their clinician counterparts. So it's very risky to give patients direct access to this kind of chatbot type of medical decision-making tools to use because they may not know exactly what kind of questions to ask directly for addressing their medical questions. So in my lab, we have been working on this project called Lab Genie, and the motivation of this is many patients now have access to their medical data through a lab portal or patient portal. But because the information presented in patient portals are very rudimentary, they are basically very medically focused, they don't provide adequate explanation about this lab result. So if your labs are being flagged as abnormal, you probably may feel anxious and feel worried, and sometimes patients don't pay enough attention to lab results that are trending towards abnormal, so they kind of miss the opportunity to prevent or change their behavior and prevent disease from happening from the first place. So there's a lot of things we need to do in order to make sure that patients have adequate knowledge and the information out of these numbers so that they can act upon those numbers in a meaningful way. So in our research, we're focused not only by presenting lab information in a more interpretable way, but more importantly is to kind of make sure that patients know exactly how to act upon it by recommending like questions patients can ask their doctors. So the goal of the Lab Genie project is really trying to develop this application as a web-based patient-facing application that provide visual presentation labs and contact information about lab results and also personal question prompt that patient can use to prepare for their kind of doctor visit next time. So we have taken a very user-centered approach in the design development of these tools. So actually, we have been working on this project since 2024. I've done, I would say so far eight user-centered design participatory workshops, and also more than 3 online experiments and online surveys to understand information needs from patients and whether providing tailored information to patients are going to be really helpful for them to get more accurate understanding of the lab's results. So we also have asked questions about AI trust, whether they actually trust AI to be able to use their data to make meaningful recommendations or generate information for them to consume. So there's a lot of new knowledge we learn in this process, which we really appreciate. And we also have worked very closely with our clinician partner in this project. So one example I want to show here is we're really thinking about how to use AI to generate qualifications upon lab result data. So this is a kind of workflow that we initially conceptualized, where we get data from electronic medical record and trying to find this clinical profile that are realistic. So basically, based on like this, we can find these cases with lab results, with medication use, with diagnosis, and we feed this data to open source models like Llama model and the closed source model like GPT-4 model, and generate question prompt based on based on the patient profile, and then iteratively evaluate the the understandability, the clinical validity, the significance of these questions with clinicians. And then once we feel, okay, these questions are adequately clinically significant, adequately kind of meaningful and understandable, we did a user-centered, we did a patient evaluation and to further evaluate their understandability and potential usefulness of these questions. So these are just some of the kind of intermediate results generated by our engineering effort for the most part, because we haven't done in this part, we haven't done any fine tuning or RAG. We just purely focused on orchestrating those prompts and ask AI whether, given this patient profile, can we generate meaningful questions for them. So you can see, even within this process, we have tried to embed more information in it, kind of prompting AI models to contextualize these questions more in the patient context. For example, considering patient medication use, considering patient procedures, etc. How we can make these questions more tailored. And then based on the evaluation results, actually looks pretty good, in terms of analytical skill rating on the questions we ask clinicians about whether they like these questions, whether they are likely to be asked in primary care setting, whether they're significant for patients. Those are all pretty good. And when we ask patients regarding the understandability and usefulness of these questions, they also give us also promising results. They also found that there are certain type of questions patients likely to consider to be useful, such as medication adjustment, lifestyle, and prognosis next steps. But when we came back to our team, we found that by providing this type of question recommend them to patients directly, it also could cause problem because it can tap too much into the diagnostic and too much into the sort of the interpretation or understandability of the actual value instead of kind of prompting patients to act upon those. So in the current iteration, we're more focused on how to modify these questions from being more on the interpretative side to more on the active side, make sure that patients can act upon those results. So there's still another round of prompt engineering we're right now working on. So please watch for the next steps. So we also work very closely with our clinician, with our developer team and UI team to develop an interface that be able to present information in an understandable and meaningful way. So for example, in this interface, patient will be able to see their basic information about their lab information in this message generated by AI, and also question patient and their doctor in the follow-up visit. And if patients would like to know further detail about their labs, they can look at the visualization, the definition, and also look at the trend of the data over time, and also the next step to do based on this information. So we have also done in the back end a series of studies that look at whether AI is able to answer questions from about lab test results posted by other peer patients. Looking at how AI is able to generate differential diagnosis based on case reports. So in this study, we focused on studies that actually are published literature about individual cases. And oftentimes those published cases are dealing with diagnoses that are not often seen because otherwise the papers won't be published. And we found that if we provide lab information, the AI model is able to generate more accurate differential diagnosis compared to not using lab information. So this confirms the effectiveness and usefulness of lab information in these particular studies. We also have looked at whether AI is able to adequately or accurately kind of respond with the accurate reference range for given lab results for a particular context, because oftentimes some lab tests are contextualized based on the age group, based on the gender, based on some factors that are related to individual groups. And we found in this study that only 50% of the time AI is able to identify the factors related to lab interpretation and people will pinpoint the specific reference ranges. So what we did is we found the credible resources from online media such as MyLab+, which is a curated information, and translate this into embedding vector space, and then using the retrieval augmented generation to augment the information being produced. We found that using RAG approach, AI is able to generate roughly 99% accurate responses to those AI kind of lab questions on reference ranges. We have recently also published a study where we curated multiple choice questions about lab information, and this could be used to benchmark language models for their answering of such questions, and also evaluating whether AI is able to provide adequately reasonable, strong reasoning to lab test related questions. So in this study, we use Julia Pearl's causal inference structure to frame these questions into associational questions, interaction questions, and counterfactual questions based on the factors that could influence labs to fluctuate and ask AI whether, for example, if you're quit smoking, whether your A1C will decrease. And we provide answers from different models, ask human clinicians to evaluate the responses and the reasoning. So the responses are pretty interesting. So I encourage you to read the paper. So for example, this is a study I mentioned how we use retrieval generation to generate accurate reference range for questions on reference ranges, and this is a study for differential diagnosis. So I just want to quickly show you a recent AI agent system framework that we look at, because as I mentioned, we have done a lot of studies to look at individual language model ability to respond to the kind of questions that are specialized in lab result. We found that we have to think about creating this multi-agent system to specialize our task into specific steps. So in a nutshell, we have 4 different sub-agents to interact with patients to collect additional information about labs. For example, symptoms related to patients and also behaviors about patients that we can better contextualize information. And then once the clinical agent look at generating the risk tiers and generating the accurate, strong enough visual visit prompt, we will use greater AI agent to evaluate the quality and then trigger clinician feedback if the quality is not above a particular threshold, and also using the communication enhancement engine to further kind of modify the language for a patient setting. So this example is, so this is a patient with NAS with demographics, with medication use, lab results, and the symptoms. And the patient AI agent is able to interpret these values and generating accurate kind of interpretation and be able to prompt patients to provide additional symptoms. And then the clinical agent is to generate risk tier, question prompt, and kind of message. And this information is being able to be graded automatically by the grader agent. And if the score is below a particular threshold, they will trigger clinician review. Otherwise, they will be sent to the communication agent to enhance their language to make sure that the language is understandable by patients and is relevant to patient context. So here is just an interface, because we don't want to expose patients to a chatbot and provide them free text question answering. Instead, we're translating these AI responses to multiple choice questions. So based on patient clinical profile, we'll figure out like what kind of symptoms can we prompt the patient provide. So these are presented as multiple choice questions with follow-up questions, and then provide some selections. And then based on our kind of clinical agent analysis, we will generate more tailored response kind of summary and the question for patient to follow for their doctors. So several considerations I just want to mention is that safeguard is very important, because any clinical decisions have to be safe, and AI generated content have to be protected, and we have to think about strong enough guardrails to ensure the validity of those responses. But still, AI agent, the challenge is that the autonomous nature of it, and what is the responsibility boundary there, and how can we ensure that humans are adequately considered for ensuring the automation is not going to harm patients or make any falsifiable recommendation to patients. And evaluation should not only be focused on accuracy, it should also be looking at other dimensions, such as safety, such as potential misleading narratives, and also we need to look at whether the understandability is adequately, reasonably, good for the responses. So even more challenging thing is how to integrate this type of tool into clinical workflow. And this is actually brought by previous panels I was in today when we talked to kind of nurse practitioners about how to integrate this type of tool in clinical decision making, because we certainly don't disrupt their clinical decision making process. And certainly regulations and the liability have to be the topmost priorities. We have to make sure that we follow so that we're not going to kind of over kind of harm our boundary. So finally, I just want to acknowledge our team for these projects and also for the support to make this project happen. Thank you so much.